Welcome to the Explainer. Today we're doing a high-yield, whiteboard-style threat assessment on pediatric skin infections. We are going to map out the bacterial heavy hitters, those sneaky viral stealth invaders, and the surprisingly expansive fungal family tree that can attack a child's skin. Whether you're gearing up for a major exam or you just really want to master pediatric skin conditions, this explainer is designed to completely lock these clinical manifestations into your visual memory.
Here's our agenda. We'll kick things off with high-yield bacterial infections, move into deep tissue and MRSA threats, quickly review viral infections, map out the fungal family tree, and wrap up with essential fungal treatments.
Section 1. High-yield bacterial infections.
Let's start right at threat level 1. These are the absolute most heavily emphasized bacterial infections from the material, and they just love to exploit minor breaks in the skin. Our first major offender? Impetigo contagiosa. You absolutely cannot miss this one. It is highly contagious and spreads peripherally through direct contact. Usually, this happens when a kid scratches a minor bug bite, which practically invites staph or strep right in. But here is the ultimate takeaway. The visual you literally must commit to memory. Impetigo erupts and then dries into very distinct honey-colored crusts. Seriously, if you see the phrase honey-colored crusts on an exam or walking into a clinic, you are looking at impetigo. Treatment relies on antibiotics, but honestly, keeping those tiny fingernails trimmed is just as crucial.
Okay, so let's see how this builds when bacteria invade the hair follicles. We need to draw a really clear line between these three so you never, ever mix them up. Folliculitis is simply an infection of a hair follicle. It basically just looks like a simple pimple. But if that infection grows, it turns into a furuncle, which you probably just know as a boil. That's a larger, swollen, red lesion, but still on a single hair follicle. Now, if that infection spreads and links multiple hair follicles together into a much larger, swollen mass, well, now you've got a carbuncle. So think of it as a direct escalation. Simple pimple, single boil, multiple boils.
Section 2. Deep tissue and MRSA threats.
As we move deeper into the tissue, our threat level escalates pretty significantly. We aren't talking about superficial crusts or little pimples anymore. These are deeper infections that can trigger real systemic responses. Highlight this in your brain right now. When an infection reaches the dermal and subcutaneous layers, we are dealing with cellulitis or erysipelas. You're going to see a firm, swollen, red, and warm area. Now, here's a really crucial pediatric distinction for you. Cellulitis is generally more common in adults, while erysipelas is a very similar presentation that's much more typical in young children. In actual clinical practice, they are incredibly hard to distinguish from one another. But fortunately, the management aligns perfectly. Both are aggressively treated with oral or IV antibiotics, depending on how severe it is.
So, what exactly happens when a staph infection decides to mount a massive, toxic attack right on the surface of the skin?
Well, it triggers staphylococcal scalded skin syndrome, or SSS for short. Now, the absolutely crucial point here is this. Despite the name, and despite the fact that it superficially looks like a scalded burn where the skin physically separates and wrinkles, this is not a thermal burn. Not at all. It's actually a bacterial toxin-mediated process. The child presents with rough-textured skin and macular erythema, and within just 2 days, these large bullae appear. Because the skin barrier is completely compromised, this requires acute hospitalization, IV fluids, and systemic antibiotics. Basically, you're treating the fluid and skin loss almost like you would a burn, but you have to attack that underlying bacterial toxin.
And of course, no bacterial threat assessment would be complete without talking about MRSA, methicillin-resistant Staphylococcus aureus. Community-acquired MRSA is highly transmissible. It can cause literally everything we just talked about: impetigo, boils, cellulitis, but standard antibiotics simply won't cut it here. Treatment typically relies on oral clindamycin or doxycycline, and you'd step up to vancomycin for severe IV cases. Prevention is paramount here. We're talking strict hand hygiene, covering any draining lesions, and absolutely no sharing of towels, razors, or sweaty sports equipment.
Section 3. Viral Infections Review.
Shifting gears to our stealthy viral invaders. Now, this is a slightly lower emphasis topic, so we're going to review these lightning fast to capture only the most testable, highly specific facts. You need to memorize these visual hallmarks. Herpes simplex virus causes your classic weeping cold sores. That's a group of itching, burning vesicles near the lips or other mucocutaneous areas. Shingles, caused by the varicella zoster virus, is just the reactivation of chickenpox, and it presents with intense neurologic pain and vesicles clustered right near nerve endings. And then there's molluscum contagiosum. Listen, this is a classic board question giveaway.
It presents as flesh-colored papules with a distinct central dimple. If you see the words dimple in the center, just think molluscum. Also, good to know, uncomplicated cases usually resolve spontaneously over about 18 months. You also need to know how to differentiate your HPV warts. A standard verruca is just a rough, gray-brown papule that can pop up anywhere on the skin. But verruca plantaris specifically hits the plantar surface, the soles of the feet. And this brilliantly illustrates how location completely dictates treatment. Because they are on the bottom of the foot, plantar warts are flat and they are painful. They require an incredibly strict protocol you need to remember: targeted pressure relief insoles, aggressive 20-minute daily soaks, and applying caustic solutions.
Section 4. The Fungal Family Tree.
Finally, we reach our fungal threats. This is an incredibly high-yield topic, but to master this, we aren't going to rely on rote memorization. Instead, we're going to build a geographic map of the body. This is one of my favorite logic hacks. The key is the word tinea. Anytime you see tinea, it simply means a dermatophyte fungal infection. That's it. The word that follows it is just a Latin anatomical term telling you exactly where that fungus lives on the geographic map of the body.
So, memorize this map. It is your ultimate shortcut, and per direct instructor emphasis, this comparison should be memorized completely. Capitis is the head, like a cap. Corporus is the body, like a corpse. Cruris is the groin or crural folds. Pedis is the foot, like a pedal. And unguium targets the nails. If you just know this map, you instantly know the location of the infection without having to guess. Ringworm on the arm? Well, that's tinea corporis. Athlete's foot? That's tinea pedis. It really is that simple.
Section 5. Essential Fungal Treatments.
But knowing the location is really only half the battle. You absolutely must match the exact fungal condition to its correct treatment matrix. So draw a line right here in your notes. Tinea corporis on the body and tinea pedis on the feet can usually be cleared up with standard topical antifungal creams, things like clotrimazole or miconazole, plus keeping the area dry with well-ventilated shoes. But tinea capitis, up on the scalp, is a different story. You can't just use a topical cream because the fungus hides deep down inside the hair follicle. That is exactly why tinea capitis requires an oral systemic medication called grisifulvin, alongside a selenium sulfide shampoo. Oh, and don't forget to treat infected household pets. Yes, the family cat might actually be the culprit. Finally, candidiasis, which is a yeast infection found in moist, peeling areas, is treated with topical nystatin.
Now, if tinea capitis goes completely unchecked, it can develop into a nasty complication called a carrion. Do not miss this one. A carrion is a severe, boggy, highly inflamed scalp lesion. Because the inflammation is just so intense, the treatment demands a highly specific, very testable combination. You still use that oral grisifulvin to kill the fungus, but you must add oral corticosteroids for 1 week to aggressively shut down the inflammation. Remember, grisifulvin plus oral corticosteroids.
Wow, okay, we have covered a massive amount of ground today. We went from the superficial crusts of impetigo right through the systemic threats of MRSA and scald skin syndrome, took a quick detour through the viral mimics, and finally charted the geographic map of fungal infections. As you review this explainer and prep for your exams, I want you to ask yourself, which specific visual hallmark, whether it's a honey-colored crust, a central dimple on a papule, or a location-based naming hack, will instantly unlock the right answer for you? Thanks for joining me on this explainer, and keep mastering those visual clues.